Hello, everybody. This is Tobias Strippel from the Heart Failure Meeting in Paris 2017. I'm here for the Young CVCT, and with us is Dr. William Abraham from Ohio State University. He's director of the Division of Cardiovascular Medicine, and we are very honored and happy to have you.
It's my pleasure to be here.
Dr. Abraham, you are a renowned expert in the field of multidisciplinary management of heart failure patients, and we're here to discuss the Which Heart Failure Intervention trial. What is your view on the trial and on the concept of these trials?
Well, first of all, I want to commend the investigators. This was a very well executed study that really looked at sort of traditional or standard of care disease management for heart failure versus a very intensive approach to heart failure disease management. And the bottom line was that it failed to show an improvement in clinical outcomes. So perhaps a somewhat surprising finding from one's intuition. We would think more intensive rather than less intensive disease management would improve clinical outcomes. But then again, on the background of prior studies which have similarly failed, perhaps the finding is not so surprising.
What would your suggestion be if we change our mindset towards these kind of trials? What is an implementation that we could pursue in getting better results for our patients?
Yeah, I think one of the biggest questions is have we already got as much as we can possibly get out of disease management per se? Is it really now essential that we move into better forms of telemonitoring or telemanagement and that we monitor the right signals? Maybe patient symptoms or daily weight changes just aren't good enough to give us advanced warning to when heart failure patients are worsening, and maybe we need to begin to do things a little bit differently.
So if we look at these telemedicine studies or at disease management program studies like we saw in the WITCH trial, a lot of concerns go onto the outcomes that are selected. A possible outcome that could be selected is days alive and out of hospital, others as hospitalizations. What do you think is an adequate outcome that we should measure in these patients?
Yeah, I think that there are a number of outcomes that are important to measure. First of all, I think patient engagement and quality of life is very important. We clearly want patients to be engaged with these disease management programs, and I think it's important that patients feel better. And quite frankly, at the very least, if we can demonstrate that patients feel better, the morbidity and mortality outcomes may in some way even be less important, because it's all about making patients feel better first and foremost. But of course, beyond that, if we can also demonstrate improvement in survival or reduction in heart failure hospitalizations, I think that would be excellent as well. Now, when you look at heart failure hospitalization endpoints, as you imply by your question, something that truly or better measures the burden of disease, I think would be very desirable to manage. So days alive and out of the hospital or recurrent rather than first hospitalizations may be good measurements.
So another aspect in telemedicine, also in the trials that you have conducted, and in the WITCH trial itself, is the contrast between a metropolitan area on the one side and more rural areas on the other. Where do you see a higher need for these kind of interventions?
Yeah, so I think it makes great sense that there would be more need in the more rural areas. So I practice in central Ohio, but many of my patients will come 2, 3, 4, 5 hours away from rural parts of Ohio, Kentucky, West Virginia, and it's very difficult for them to get to the clinic frequently. I'd like to see them frequently, but I can't see them as frequently in the clinic as I would like. So using remote telemonitoring and disease management programs that can take advantage of new technologies and reach into their homes, I think is very good. Using local resources such as visiting nurses or other healthcare providers that can go into the patient's home, I think is another way to do that. But again, I think based on the results of the WITCH trial, we haven't yet figured out exactly how to optimize that paradigm to improve patient outcomes.
Thank you for this insight. Personally, it's very interesting for me because I come from a health system that is very based on the physician itself, and you have a lot of experience with these multidisciplinary teams, also with community-based teams. Where do you see the role of an academic center as a center of excellence to be kind of a pacemaker?
Yeah, I think the academic medical center really needs to be the leader here. In a hub and spoke sort of setup. So academic medical centers can provide some of the core resources to telemanagement, disease management programs. They can serve as a sort of centralized, clearinghouse to standardize protocols and to implement them in the community. But you have to have spokes. You have to have spokes that surround this wheel that make it all work. And there I think it's the social worker, the nurse or nurse practitioner, the primary care physician, people who are in the community day in and day out on the front lines of managing these patients who can be very helpful.
Thank you so much, Dr. Abraham, for your inspirational talk, and thank you for sharing your time with the CVCT.
My pleasure. Thank you.